I want to welcome everyone to this morning's event, particularly those, everyone, whether you're in the room or you're visiting and viewing in online on YouTube or Facebook. Welcome to Moving Forward. This is World Mental Health Day. October 10th is World Mental Health Day, so it's being acknowledged in several ways in our community. This is our effort today to recognize that and get some terrific awareness and training and conversation for us today. So thank you for joining us. I didn't introduce myself. Hi, I'm John Gregory with Samaritan Counseling Services of the Gulf Coast. This is one of the kinds of events we like to put on occasionally, and it's not our people putting on the presentations. We bring outsiders in to help us expand knowledge and awareness, and so we're very thrilled to have our two presenters today to do that for us. I do want to mention, and you'll hear this repeated this morning, just sort of a trigger warning for you. The content you hear this morning, excuse me, will include references to things that may be a trigger for you. So feel free to, if you need to leave the room or step away from your device that you're watching through. Suicidal ideation will be mentioned, abuse, schizophrenic symptoms, near-death experiences, those kinds of things. So just want to acknowledge that and make sure that you're taking care of yourself as you need this morning. For those of you mental health professionals in the room who or online who are looking for the CEUs from this morning, for those of you present, there are forms out on the registration table that we need you to complete before you leave today. So make sure you get those. If you didn't get one and fill those out and leave that either on the table or with one of our staff. With Samaritan, we got 4 here and 2 ladies at the table already. So leave that with us, and we will submit those for you. You don't need to do anything but turn in the form. For those of you who are streaming, if you would like to also submit for that, you will need to just send me an email. And here's my email address, so I'll put it on the screen for you. It's john@samaritangulfcoast.com. Just send me an email, and I will send you a link to an online form that you can complete for that. And we want to make sure to give you the credit for those things. I think that's all I had to say, except I will say in your bag also is just a quick program reminder of the morning. And on the back, if you didn't get a bag, I'm looking like, where's the bag? It's at the table. We'll get you a bag. Okay, I'll make sure you can get one to you. There's a list of our exhibitors that are back in the back of the ballroom. So you just want to take time to, if you haven't already, take time to get to meet them during our break times and learn more about them. Harmony Harbor also sponsored the event this morning, so thank you, Harmony Harbor. And then we have representatives here from Centerstone and Dr. Greeter's psychiatry office, so thank you very much. And our 2 presenters also have tables in the back, so as they reference their resources and their books, I would encourage you to stop back there during our break time and look at those as well. So let me go ahead and make sure I give them all the time that we've promised them. And I want to introduce our first speaker and welcome her to the stage. Amy Weisman de Mamani is a professor at the University of Miami. Is also a licensed clinical psychologist. She earned her doctorate at the University of Southern California and completed her clinical internship at UCLA. That's interesting. Both of those, like across the street almost from each other. Her research is focused on family and cultural factors that influence the course and outcome of serious mental illness. She's published over 100 manuscripts in areas related to mental illness, and I just noticed back on her table, like freshly produced book that I'm sure you'll reference this morning. So we're so glad that you could drive over and be with us this morning. Please welcome Amy Weisman de Mamani to the stage.
Good morning. I am thrilled to be here. Thank you for that lovely introduction, John. As John mentioned, I'm a clinical psychologist by training, and I've spent the better part of my career studying family and psychosocial factors that influence the course of schizophrenia and related serious mental illness and building treatment interventions based on some of these findings to try to help people with these illnesses and their families manage the course and live fuller, more connected lives. Before I delve in, I want to say a few words about how I came to be here today. A couple of months ago, I got an email from John asking if I'd be willing to come and talk about my research in schizophrenia and about my intervention, something I'm always happy to do. And then he mentioned that I would be speaking alongside Todd Akron Crush, the author of this amazing book, From Beneath the Ice. And he asked if I knew Todd and if I had read Todd's book. And I hadn't, and he set up a meeting for us to prepare for this summit today. And I ordered the book, and I think it's accurate to say I devoured the book in probably a day and change. And Todd will, in his own words, tell you his story. I imagine he will speak about the book in his own words. But I said to him when we met, you know, Todd, you could really be the spokesperson for my culturally informed therapy. The way he has navigated his illness is so inspirational, and I feel honored to share the stage with him today. I will briefly reference some of Todd's writings in my talk, things that he's talked about himself, but I won't steal his thunder. He will talk about his own lived experience in his own words, but I hope that you can see how my research perspectives and that I've learned through my clinical work and research and that of others and my views align with Todd's lived experience in managing this illness that can be, very challenging. And I think this synergy is we need more of this to work alongside people with lived experience to improve our interventions and vice versa. So again, I am so honored to thank you, John, for coordinating, and thank you, Todd, for sharing the stage with me today. Let me give you a quick roadmap about what I'm going to talk about. So I will give a very brief overview of schizophrenia and its causes. I will talk about research that really informed the development of the culturally informed therapy that I'm going to present on today, and I'll talk a little bit about some of our findings. And hopefully, if there's time, I can talk about how we're taking this research and some of our future directions. So I imagine that most people in the audience and on the live stream are in some way acquainted with serious mental illness. Either you're practitioners or you are family members of someone, or you have a serious mental illness. So I won't go in depth about what the disorder is and the causes, but it is considered to be one of the most severe forms of mental illness. It impacts many domains, one's thought processes, one's mood, and functioning. And you can try to imagine trying to follow a conversation where words feel scrambled or disconnected, and understanding tone or intent like sarcasm or metaphor feels like a struggle, and a person's mood can be unpredictable or numb. Even everyday tasks, sometimes like getting dressed, managing time, and navigating things like public transportation can be overwhelming. And something I want to mention now is that because the behaviors when somebody is in the midst of a psychotic episode can appear unusual and scary to someone who isn't familiar with them, there is a widespread myth that people with serious mental illness are dangerous. In reality, this perception is gravely overestimated. Individuals with serious mental illness are far, far more likely to be the victims of violence than the perpetrators. And unfortunately, this perception carries into things like law enforcement and can sometimes lead to unnecessary violent interactions between police officers and people with serious mental illness. And I hope to revisit that at the end of my talk. So I want to say that this disorder has a complex relationship with biological and environmental causes. It is a highly heritable disorder. This just means that genes play a major role in determining who may get the disorder. It's no guarantee if you have a close relative that has it, you will get it, but your likelihood is much higher, and there's neurochemical changes that we see in dopamine and glutamate systems that these don't seem to function similarly in people with this disorder, and this is often associated with excess levels of dopamine and the like with excess symptoms. And there are some prenatal influences as well, complications during pregnancy, infections, and things like that are thought to be more, they make it more likely that a person that has a genetic risk will experience the disorder, but they don't cause the disorder per se. And although schizophrenia is a genetic disorder, environmental factors like early life trauma, abuse, and neglect, Todd is going to share his story and how these factors influenced his life. These environmental factors, including discrimination, poverty, and isolation, arguably carry more weight in how these disorders progress than do the biological factors. Even something as basic as taking one's medication consistently depends on a person's surrounding and their support system. Other environmentally related things that won't cause the disorder but account for a much poorer course are also the use of substances. They're not good for anyone, but they're exponentially worse for somebody who's already compromised and having symptoms. Schizophrenia, the prevalence rates of the disorder, it affects about 1 in 100 people worldwide, and that is a fairly robust estimate. It hasn't changed very much over the years, and it looks pretty uniform around the world, while we do see some blips and pockets of places with higher and lower. Black people in the United States have a worse prognosis than their white counterparts. Something that is very interesting is that only is in countries where they are the minority in numbers, so that is not the case in Africa. It's the case in the United States and England and other places, so that's telling, and maybe that's something we can talk about more in the Q&A. I'm not going to focus on that line of research today, although I've done some. I'm going to focus on other minoritized groups in the United States and in the world that actually, in many ways, this sounds counterintuitive, but they actually have a more benign course, a better course of mental illness, despite usually developing countries usually have lower SES and minoritized groups. I'm going to focus on, because this is where my research has taken me, mostly on people from Spanish-speaking countries in the United States. We see a Hispanic paradox in that they are economically lower SES, less likely to have insurance, yet they live longer and they have lower prevalence of most mental disorders than their non-Hispanic white counterparts. So I'm going to talk about that because trying to understand that has really been the basis of my career. I became fascinated with early findings by the World Health Organization that these large institutions really had, they conducted a series of studies using standardized assessment procedures in numerous countries around the world, where they were also incorporating locals to make sure they were getting the nuances of the language right, and the same protocol. And they found in multiple waves of studies in the early 70s, in the late 70s, again in the 90s, that people with schizophrenia and other psychotic spectrum disorders who reside in industrialized countries, the United States, England, and Canada, had a less favorable course, not the prevalence rates are pretty similar, but a less favorable course than their counterparts who reside in more developing countries. I'm usually going to use the word traditional rather than developing, because developing is really getting at income, and I'm focused more on variables. When I say traditional cultures, I mean cultures that tend to put group goals over individual goals, that tend to have clearer codes for behaving, and so I will be kind of defining what I mean and why I think that people from those cultures may fare better when they have a serious mental illness. And so these are some of the variables. They look yellow or orange on my screen in the middle that I am going to zero in on, that I have examined in my own research to help me understand why we might see these cultural differences, and how can we try to isolate what the ingredients are that account for that, so we can build them into better interventions. So I'm going to start by talking about the emotional climate of a household and its relationship to the prognosis of the illness. One of the most widely measured psychosocial constructs in psychiatry and psychology is this very simple rating of the emotional climate. It's called expressed emotion, or more affectionately for those of us who study it, EE. And it's a measure of the amount of criticism and hostility mainly, and there is another component, emotional over-involvement, which is when a parent is overly intrusive or overly self-sacrificing as well. People with schizophrenia and now a host of other disorders who this early research in this graph is from a meta-analysis of people with schizophrenia. A meta-analysis just means that there was multiple studies from around the world showing that for patients who have an index episode, that means the first time they were hospitalized with a psychiatric illness, who return to live in households where relatives were designated as high in expressed emotion, they were critical, they were hostile, using standardized measures called either the Camberwell Family Interview or a shorter version of that, the 5-minute speech sample, which has excellent concordance. If one says the person's high EE, so does the other. Those folks that were released to the hospital to live with high EE, to live in high EE households, are twice as likely to relapse within a 9-month period compared to those who return to live in warm, empathic environments. That's not rocket science. Nobody functions well in critical and hostile environments, but for people who are already compromised, it really is, it's not conducive to managing an already very challenging illness. And these findings have now been extended to, related disorders like bipolar and depression, but also things like conduct disorder in children, eating disorders, and so it's a finding that really relates to managing any adversity. People don't do as well when they're not in environments that are supportive. So I was very interested in that finding in my early work about why do people from about the WHO findings, why people from more traditional cultures have a more benign or better course of illness. And I wondered if the expressed emotion construct, because we see this Hispanic paradox in the US, would that tell us something? Could there be higher base rates of high expressed emotion in our non-Hispanic white families compared to our Hispanic? And I want to say this very briefly, but in my slides you'll see me use sometimes Hispanic, sometimes a variation of Latino, Latine, or Latina, and that is because In the East Coast of our country, Puerto Ricans and Cubans tend to prefer the designation Hispanic. I could spend an hour talking about that alone. On the West Coast, some version of Latine is often preferred, and so it depends on who I'm examining at the moment, and also over the years the language changes, so that's why there might be some discrepancies in my slides. But back to this study, I wanted to see if we might see higher rates of high EE in our non-Hispanic white family members. Could that tell us something? And so I had funding from the NIH at the time, and I took my research team, which is usually whichever graduate students are in my lab, so I should give a shout out to them because I couldn't do any of my research without them. But we went to 3 cities, Boston, Miami, and Los Angeles, and we interviewed white and Hispanic family members using these measures, the gold standard measures that I mentioned a minute ago, the Camberwell family interview and the 5-minute speech sample. And we found, lo and behold, that our non-Hispanic white participants were 3 to 5 times more likely to be rated as high in expressed emotion than our Hispanic families. I say 3 to 5 because it depended on which measure we were using. And I'm going to link that back up to culture in a minute. Why might that be? But in 2 other studies, we found that the attributions, and when I say attributions, I'm referring to the causal beliefs that family members have about why their loved one is ill and their views on how much the person could control the symptoms of the illness and the onset. And we found that high expressed emotion relatives were more likely to see the cause and mainly the maintenance of the disorder as the patient's fault to some degree, meaning that it's something that they should and could do a better job managing, and sometimes even the onset, more so the management of it. And this was a culture general finding. It was true for whites, it was true for our Latino clients, and the overarching model supports basic findings in social psychology. If we perceive an action or an event for an adverse event of another person as something that they brought on to themselves or didn't help themselves control it, we're likely to be angry, frustrated, not so willing to help. If we see it as something that's out of their control, we're much more forgiving. And I would like to use an example of from Todd's life, from Beneath the Ice. He talks about going into the wilderness for years on end. If his loved ones see, Todd, I'm talking about you, if his loved ones see this as, because Todd was so unwell, he didn't have any other way of managing that, they're likely to make uncontrollable attributions, and they're likely to respond with warmth and empathy and a desire to help Todd financially or emotionally. Yet if they make an attribution that this was somehow a choice to shun work-related activities or childcare or whatever, the emotional responses to the exact same event could be anger, frustration, and as in turn, less of a desire to support Todd in whatever way. And so, again, this is basic social psychology. Most of it is very intuitive. But I wanted to see, could we see base rates differences in the attributions that people from these traditional cultures that have a more benign course make towards their family members. And so in this study, it was an analog study. It's the only study that was not with actual family members, and we did that because we wanted experimental control over what the participants saw. So for this study that I'm going to talk about right now, we created vignettes of a fictional person named Victor who was described to meet the diagnostic and statistical manual criteria for schizophrenia. They were asked to imagine that this person was their brother, Victor, and we conducted this study in the U.S. and Mexico, so the measures and everything was translated and back-translated into Spanish, so participants were seeing the same description but in their own language. And we used college students who are psychology majors in a expensive private institution in the U.S., University of Southern California, and a comparable university called ITESO in Guadalajara, Mexico, also psychology students, so comparable ages, comparable areas of studies. And we asked participants to read this vignette and then to tell us if this were your brother, how are you likely to see the illness? How much control does Victor have over managing? And we asked, breaking down the types of symptoms, and they rated those. How much frustration and anger and a series of negatively balanced emotions do you think you'd feel towards your sibling, and the flip side, all of these positive emotions? And in turn, how willing do you think you would be to help your brother? Well, we found support for Bernie Weiner's model completely across the board for both sets of participants. Again, that's a known factor. If we make negative attributions that are controllable, then we're more likely to feel frustrated and angry and not likely to help. What was new and what was striking is that we found that our non-Hispanic white participants made more controllable attributions towards the symptoms and expressed more intense unfavorable and less intense favorable emotions and less willingness to help their hypothetical symptoms. So this gives us some support for why we might see these differences that the World Health Organization has found in multiple highly controlled studies. And it also so it gives us some insights into what we might want to work with families and patients on in intervention programs. I do want to take a moment to say, why would we see this? And so I want to spend a minute saying, if you think really about the United States and some of the prevailing philosophies, even from our forefathers, there is this notion that with hard work, one can rise from rags to riches. You can overcome anything. It's the American dream. That philosophy is amazing, and people can accomplish all sorts of really difficult feats when they have that philosophy. Todd is our example. So it can be great. When it breaks down is when it is applied to other people in circumstances that might really be beyond their control. To some degree, schizophrenia is a disorder that you can manage beautifully and you can live a productive life. But there are some points in this disorder that the patient is neurochemically imbalanced and they can't do the things that maybe they could do before and will do again. And so that's when it breaks down. I think it's important to mention, in our scales, our white families don't love their relatives or care any less about them. They just have a different set of attributions that is really adaptive in some settings and not so much in others. So I think that's important to point out. The next area I'm going to talk about is religiosity and spirituality. When I was doing some of my early research, driving around Los Angeles and interviewing family members, I kept hearing references to their faith as a coping mechanism. And we do know that people from traditional cultures tend to not only be more religious than their white counterparts, but they tend to integrate their faith more into their day-to-day lives. I have a quote on the screen about that I think captures the essence of many of these comments. They're using their faith to manage something that's really, really difficult. And so then I started to wonder, could that be another factor, that there's this whole meaning framework? There's also a support system that comes with religious institutions. There's notions that we know from secular versions of psychology, forgiveness and empathy. All those are associated with better mental health. And so I started pouring through the literature. And in that time, in the early 90s, even on covers of like Newsweek and Time, there was all this research cropping up about how religious people tend to be healthier, happier. My colleague, Mike McCullough, a few years ago did a meta-analysis looking at all-cause mortality, death for any reason. And guess what? Religious people live longer than their non-religious counterparts. And so we wondered about taking the components, both secularly, the ingredients of what is it about religion that helps people live better lives and to avoid some behavioral triggers. They're less likely to abuse drugs and alcohol and things like that, and work them into our treatment program. The last area I'm going to talk about is family cohesion. As I said, our white families, especially those that are coming into treatment, they love their family members. We do see, and actually there's no differences in how the two groups score on their measure of family cohesion. I'll talk about that a bit more. We did find, and again, I think this is intuitive, we found that for people with schizophrenia and their family members, if they view their family as more cohesive, more supportive, more loving, the people with the illness not only have less severe psychiatric symptoms, both them and their family members have less depression, less anxiety, less stress. And so really building that into our treatment programs, but also trying to capture a little bit of the collectivistic flavor of the more extended family networks, the seeing the person as an extension of themselves. It sounds like it goes against the grain of psychology where we try to foster independence, but that may have a lot of merit here. And so we took research from our own findings and from our colleagues' findings, and we built this intervention. I published the treatment manual for this in 2021, and it's a 5-segmented intervention. I'm going to talk very briefly about each of the components. The first one, family collectivism, is aimed at really trying to fortify a strong sense of family unity and helping the members in the family view themselves as a team that's working towards a mutual goal, and trying to deflect the blame away from any particular family member, so not the person with the illness. This is the target is the family themselves. And there's a lot of ways that we do this. One is right off the bat, the fact that the family members are in the room shows that even if they don't see eye to eye on anything else, they're committed to the family because they're coming here. And so we talk a lot about what they're hoping to gain, and usually it's another guaranteed opportunity to show some commonalities, because they're almost always there because they want so-and-so to get better, or they want their family to function better. And so right there, your important goals are similar. You might not be in agreement on how to get there. We talk about what the concept of family means and try to get them to come up with some, agree on some characteristics that they all want to strive for in their ideal family, their own family and their ideal family. We have homework for every session of this because we want it to be integrated into their day-to-day lives. So we ask them to explore their families, exploring their traditions and their the things that they like to do together, and encouraging them to actually set aside time to do things that are connecting, because that's what we think is some of what counts for the better course of illness in traditional cultures. And it's not just that they love their families, they have each other's backs, they're spending time together, they're prepping meals. So we're encouraging it doesn't matter what their family background was. We do this for our white families and our the clients that already tend to do that as well. And then in the second module of the intervention, we spend a lot of time talking about the psychoeducation of managing schizophrenia. So helping the family understand the biology of it, getting a clear sense of their culture's view of the disorder, and this can help with dispelling any stigmas that they may have around it, or how it may be viewed as something that makes them feel like they're damaged rather than just simply ill, like if you are a person with diabetes or cancer. So we spend a lot of time on that. We spend a lot of time talking about the symptoms, usually what we call the positive symptoms, and there is nothing positive about these symptoms. The behaviors that are the hallmarks of this disorder, like having hallucinations, so perceptual experiences that others wouldn't have, and the delusions, having beliefs that most others in your community wouldn't believe. Those things the family usually recognize as symptoms because because they're unusual. It's really the negative symptoms, those that occur below a baseline. The person has very restricted range of emotion, or they don't want to shower. Those are the things that are more likely to be targeted in those high EE comments, because they think that those are things that are personality and that the patient can and should do better. And so those are the things that often need more attention. So we spend a lot of time on that. We also spend a lot of time on depression and anxiety, because if you're managing this disorder, it's challenging, and so the people with the illness themselves often have high levels of comorbid depression and anxiety, as do the family members, and this is helpful for using the true and tried cognitive behavioral ways. These symptoms respond very well to intervention, and it's also helpful for shifting the blame and the focus of therapy away from just the person managing the serious mental illness. It's an opportunity to really work to improve the lives of the family members. We talk about the genetic background. I mentioned this a little already, to help them understand it in the way you might understand a predisposition to diabetes, to take the stigma away. And then we talk about the comorbidity with substance abuse, which unfortunately, because it's a burden to have this disorder, and people with it often self-medicate, and unfortunately, psychosocial cognitive behavioral interventions, which ours is, don't respond very well if a person is also using drugs, so we hit that really hard when we need to. And we talk about how the family can help. Speaking a little bit rapidly now, because I think I'm running close on time, but the third module we developed is spiritual coping, where we really try to help our families tap into religious or existential, if they're not religious, beliefs. So we talk a lot about their participation in, or their desire for participation in religious communities. We talk about support system they have. It could be other types of community settings that aren't religious but have the feel of a community. You probably wonder, what do you do if a client or a family comes in and they're not religious? And we never make any attempts to steer people towards a religious point of view. We just focus on philosophical beliefs about right and wrong. We have parallel handouts for people who are not interested in a religious intervention. They might, instead of praying, they might meditate or go to yoga or walk in nature to be connected with the universe. So it's that we're getting at the same, we hope, same things. And so we're trying to foster more positive attitudes of forgiveness, gratitude, generosity. All of these things are associated with better mental health. And we might encourage them to bring in writings that speak to them. So it could be biblical passages or self-help kind of writings or poems for those who are not religious. So they're using the intervention and in there and bringing it in from their outside lives. And the last two modules I'm going to mention briefly. Communication training we use to try to help people with this illness and their family members be better advocates for themselves. So we teach them a series of skills and how to approach things so they don't alienate others, but they're clear and concise about what they want. And we use this to lower the expressed emotion in the household. So they're taught to speak and make sure that they're really conveying the point it is that they want to convey, rather than generalizing to the person, and that they're listening actively, so that they are looking at the person when they speak, and before a person responds, that they're paraphrasing back to make sure that they are indeed hearing what the person said and not responding to some other thought that's in their head. And I say this for people with mental illness and without. In many families, even without mental illness, people talk past one another without really listening, and so they're thinking about what they're going to say and not hearing the other person. And that's confusing and lends itself to arguments, but it's especially confusing in people with mental illness who already have often many communication deficits. And so we spend a lot of time talking about cultural communication patterns, like what are the norms of communicating, and making sure that we're not encouraging them to engage in patterns that would be disrespectful, but also having them evaluate their patterns. And I'm going to say the same thing about the next segment, to really think about, we all have limited emotional and time resources. And so thinking about picking their communication battles wisely in line with their cultural values and beliefs. So, for example, I'm thinking of a case where the parents wanted their adult son with schizophrenia to go to church, and he was happy to do that, but he would often wear ripped jeans. And so we could talk about what can you live with, what can we let go of, and to free up time for things that really matter to you and your family. And so we teach them also to focus on specific behaviors. I really would appreciate it if you wouldn't leave your dishes in the sink rather than you're a slob, and things like that are much more likely to trigger an argument and a shutting down. And then for the problem solving, which is the last segment of the intervention, we teach family members specific techniques to try to make them more efficient problem solvers. And so the most important thing is really to get them to operationalize what it is they want to work on. And you can use all of these exercises for individual problems and for family problems, but often we see when we do that, they're not even arguing about the same thing. And so we spend time saying and it's really hard to make progress on a goal if you don't even know what you're trying to work on. So we have them really decide and fine-tune, like you would with a research measure, what it is they're working on, and then we have them throw out all sorts of ideas from everybody without evaluating them. So good ideas don't get tossed prematurely, and sometimes a lot of knowledge comes from bad ideas. You know what you don't want, and there might be parts of that bad idea that are great. And so we teach them these skills. And here we talk a lot about their approaches to problem solving in their culture. And again, you don't have time to challenge, not everything needs to be labeled as a problem that needs to be solved. So picking their battles in line with their beliefs and values. So we tested this intervention, culturally informed therapy, CITS, against what we were initially calling treatment as usual. When I submitted this project for publication, a reviewer astutely pointed out that family therapy, only about 4 to 7% of people get, so it's way better than treatment as usual. We tested against psychoeducation, which is an effective intervention, so family psychoeducation. And just for our overarching findings, we found that our CITS outperformed psychoeducation. The lower bars are good scores because it's the variable that we were looking at for this graph on the left for you as well. The BPRS is a measure of psychiatric symptoms, brief psychiatric rating scale. We found that the families that went through CITS, the person with the illness, had less severe symptoms at termination. Now, this is controlling for their baseline score, and this was something we refer to as a median effect, so a really respectable outcome. And then for the family members, CITS outperformed psychoeducation, again, controlling for baseline scores on caregiver burden, and it was a large effect, so even more useful for the family members managing. And then we looked at other outcomes, depression, anxiety, and stress. We found that the intervention also outperformed psychoeducation on reducing those factors. But in this study, we found that the mediating variable, so the variable that really seemed to account for that improvement, was family collectivism, getting the family to really feel more cohesive and like a team had an influence. It didn't account for all of the variants, but it had a big influence on the improvements that we saw. In this particular study, in 2020 hindsight, we didn't evaluate religiosity very well because our goal wasn't to make people more religious. We didn't see pre and post changes in their religiosity. We weren't trying to. We were trying to get them to utilize their faith to manage their illness. So we didn't see changes in that. Cross-sectionally, we did see the more religious our clients were, the less severe the people with the illness's psychiatric symptoms were, the better quality of life on two different measures the family members reported. But we wanted to delve in a little bit more to why we might have not seen changes. And one of my students found in her doctoral dissertations that our religious clients were actually leaving us more often, were more likely to leave us prematurely. And she did something called survival analysis, where we looked at when the clients left, and found that almost all the participants, if they left, they were leaving in the early sessions, and at that point our spirituality module was in the middle of the treatment. The attrition rates dropped to 0. If they went through that module, nobody left. And so this made us realize we were probably, with our religious clients, missing a critical gap, and that we lost them before we got there. So in their mind, the intervention didn't align with their beliefs. And I should say we had really good retention, so it wasn't a lot of people that left us, but if those that did were more likely to be religious. And so the intervention does seem to decrease symptoms. It helps family members feel less depressed, burdened, and anxious. And this seems to be driven by increasing family cohesion. And I think the jury's out for religion. So I am just going to mention briefly, and we can talk more about this at the Q&A. We've extended this intervention. There's really only one module that's unique to schizophrenia, to all sorts of other populations and disorders. We offer multifamily groups where we now integrate religion from beginning to end. We start with a prayer or a reading. We talk about it in every session, and we are tailoring it to populations at high risk. So John referenced this, we just published a manual for Muslims because right now, for the last decade, Muslims in the U.S. have high rates of depression and suicide, unfortunately. So, and it's a population that doesn't tend to seek mainstream psychotherapy, so we're really working on that. And I think more importantly, for today's talk, this is the last thing that I will mention, is my research team is just starting a project to really work with police officers to try to improve their relationships with people with mental illness. Tragically, about a quarter of all fatal police encounters do involve a person with schizophrenia or a related mental disorder. And, police arguably have one of the hardest jobs that there are, and the data shows that they're a group that has 5 times the rate of post-traumatic disorder. They have twice the rate of major depression. It's a really stressful job, and so it's not surprising. But what is scary about all of this is not only are their culture such that they're taught not to ever show weakness, so you would never seek psychotherapy, so they don't have an access to that. But our research is showing that the more that they are mentally unwell, distressed, anxious, suicidal, and the rates of suicide among officers is alarmingly high, the more likely they are to be stigmatizing towards people with serious mental illness. This isn't something bad or about officers. It's human nature. That's straight out of social psychology again. When we feel bad, we're meaner, we're more aggressive, we're more verbally and physically likely to lash out at others. And so it's really critical, I think, that officers get the support they need and deserve. They have a really tough job. They need to be educated more about the mental illness myth. We have data showing that they subscribe to that just like lay people. I mean, they're human beings as well. And so some of that through education from police force and the like, and changing the culture so that it's okay for an officer to seek help when they're depressed and stressed. I hope that we can also reduce this statistic, and I'll end with that. Thank you.